Picture this. It's 2:00 p.m. on a Tuesday. You're on rounds, stroke unit. You're at the foot of the bed. 74-year-old gentleman, we'll call him Mr. Henderson.
Yep.
Ischemic stroke. Clearly cardioembolic. You see the AFib on the monitor. You know the mechanism. You know exactly why he's here.
And then comes the decision.
And then comes the decision that I think keeps us all up at night.
The timing decision. When do you start the anticoagulation?
It's the classic. I mean, it's a definition of being between a rock and a hard place.
It really is. It's that internal tug of war. On one side, your brain is just screaming, there is a clot factory in his left atrial appendage.
Right.
If I don't shut it down, he's going to throw another embolus and wipe out whatever function he has left. That's the fear of recurrence.
And it's a very real fear.
Yeah.
But on the other side, you're looking at that fresh infarct on the MRI, that damaged tissue.
Yeah.
And you know it's necrotic. The blood-brain barrier is just shattered. So if you pour a blood thinner into that environment, you risk turning a manageable ischemic event into a catastrophic bleed. First, do no harm. But in this specific context, doing nothing feels like you're also doing harm. For decades, I feel like we leaned so heavily on the side of caution.
We did. We were almost paralyzed by the fear of the bleed. Remember the old dogma, the 1-3-6-12 rule?
Oh, the Nell rule.
Yeah.
It was practically gospel when I was in training.
Exactly. For anyone who needs a quick refresher, you wait 1 day for a TIA, 3 days for a mild stroke, 6 for moderate, and 12 for severe.
It was clean, it was linear, and it felt safe. Or at least we thought it was safe.
Right.
But that's what we're really digging into today. The data has shifted under our feet. We're moving away from that sort of rigid calendar-based conservatism toward a more aggressive physiology-based approach.
That's the perfect way to put it.
The question isn't just how long do we wait, it's why are we waiting, and are we waiting too long?
That is the crux of it. The modern consensus is absolutely shifting toward early initiation. And when we say early, we aren't talking about day 14 anymore. We are talking about the 48-hour to 7-day window.
Okay, let's dig into the why before we get to the who. Why the push for speed? Is the risk of early recurrence? Is it really that high?
It is, especially in AF. See, with something like large artery atherosclerosis or small vessel disease, the mechanism is, relatively static. But with AF, you're dealing with a dynamic instability. The heart is still fibrillating. The substrate for thrombus formation is active right now.
So the risk of that second hit is front-loaded.
Heavily front-loaded. The data suggests that the risk of early recurrent ischemic stroke within that first week or two was likely underestimated in a lot of the older trials.
And at the same time, we were probably overestimating the bleeding risk.
Exactly, especially now that we use DOACs instead of warfarin.
That's a key variable, isn't it? Warfarin was so unpredictable. You start it, and you're chasing an INR for days, swinging between subtherapeutic and, toxic.
It changes everything. With a DOAC, you turn the protection on like a light switch. It's immediate, it's predictable.
So the logic follows. If we have a tool that works instantly and is safer, why leave the patient exposed to recurrence for 12 days if we don't have to?
Precisely.
Okay, so the philosophy is start as soon as safely possible. But that word safely, it's doing a lot of heavy lifting there.
A lot.
We can't just throw a Pixaban at everyone on day 2. We have to stratify. So let's talk about the green light group. Who are the patients where you feel confident starting early, say, day 3 or 4?
The green light group is your mild to moderate strokes. But we need to get more granular than that. We can't just eyeball it and say, oh, he looks okay. We should be looking at the NIHSS score.
Okay, give us the numbers. What's the cutoff we're talking about?
Generally, for a mild stroke, we're looking at an NIHSS score under 8. That's a pretty common threshold. You might push it to 15 or 16 for moderate, depending on the specific protocol.
But less than 8 is the sweet spot.
That is your sweet spot for confident early initiation, yes.
And what about imaging? Because a clinical score can be deceiving if the infarct is in a silent area of the brain.
Crucial point. You absolutely have to look at the lesion volume. For the green light group, we're talking about small infarcts, physically small. Usually less than 1.5 or 2 centimeters.
So if I have a patient, NIHSS of 4, a small cortical infarct, no visible blood on the baseline scan, and their blood pressure is controlled.
Day 3 or 4, go for it. The evidence is very clear that starting early in this group significantly reduces the rate of recurrent ischemic stroke.
Without a major increase in bleeding.
Without a statistically significant increase in major bleeding, exactly.
It almost sounds like for the specific group, the old wait-and-see approach might be, well, malpractice is a strong word, but you're leaving the door open.
It is a strong word, but you're not wrong. In the mild group, the net clinical benefit heavily favors an early start. We aren't just guessing anymore. We have robust registry data and major trials backing this up.
Okay, so that's the easy group. Mild stroke, small doubt on the MRI, start early. Now let's get into the weeds. The red light scenarios. When do we pump the brakes?
This is where understanding the physiology is just non-negotiable. You mentioned the blood-brain barrier earlier. We need to really visualize what's happening in a severe stroke.
Right, we're not just talking about dead neurons. We're talking about the structural integrity of the vessel walls within that dead tissue.
Precisely. In a large infarct, let's say a big MCA territory stroke, the ischemia causes necrosis of the vessel endothelium itself. The barrier that keeps blood inside the pipe, it breaks down. It becomes leaky.
And if you introduce an anticoagulant into a system with leaky pipes,
You get extravasation. You get blood leaking into the prima. That is hemorrhagic transformation. And that is why stroke severity is the #1 reason to delay.
Okay, so let's define severe for everyone listening. We said NIHSS less than 8 is mild. What puts you in the danger zone?
Usually we get very nervous when the NIHSS climbs above 15 or 16. But honestly, more importantly, look at the volume on the scan.
Right.
If you see a large territorial infarct, taking up a third of a hemisphere, something significant, that is an immediate red light.
Because the sheer surface area of damaged leaky vessels is just massive.
Correct. The probability of a significant bleed is proportional to the volume of the infarct. In those cases, even if the patient is clinically stable, the brain tissue is not. It needs time to organize, to scar down, to stabilize.
So for those large infarcts, we're still sticking to the delay strategy. Are we talking the full 12, 14 days?
Generally, yes. The guidance suggests pushing that start date back to at least day 12, maybe 13 or 14. And critically, you want to repeat the imaging before you start.
Of course, just to make sure nothing's changed.
Right. Get a CT or MRI to make sure you haven't developed a silent hemorrhage in the meantime.
Speaking of hemorrhage, let's talk about hemorrhagic transformation, or HT, because this isn't binary, right? It's not just bleed or no bleed. There are grades.
This is a nuance that gets missed a lot. We usually use the ECAS classification. You have hemorrhagic infarction HI1 and HI2, which are basically petechial bleeds, little spots of blood within the infarct.
Like spotting. It's not a true hematoma.
Exactly. And then you have parenchymal hematoma PH1 and PH2. Now that is a dense clot, a space-occupying lesion of blood.
I'm assuming any pH type is a hard stop.
Absolute hard stop. If you see a PH2, a large hematoma with mass effect, you are not starting anticoagulation anytime soon. You might be holding off for weeks, repeating imaging.
Maybe even considering left atrial appendage closure down the line.
Exactly. If you decide you can never safely anticoagulate.
Okay, but what about the petechial stuff, the HI1s? I see those on radiology reports all the time. Scattered petechial hemorrhage within the infarct bed. Does that kill the early start strategy?
Not necessarily, and this is where the sophistication really comes in. A little bit of petechial bleeding is almost part of the natural history of a reperfused stroke. It doesn't always predict a massive blowout.
So you're saying we might still anticoagulate a patient who has some mild petechial hemorrhage?
In select cases, yes. If the stroke is otherwise mild to moderate and the bleeding is strictly petechial, HI1, many neurologists will still proceed.
But maybe with a slight delay.
Perhaps with a slight delay, say day 7 instead of day 3, but they won't withhold it indefinitely. But you have to watch them like a hawk.
That really feels like the yellow light zone. Proceed with extreme caution.
It is, and it requires shared decision-making. But the key takeaway is this. Don't treat a speck of petechia the same way you treat a massive hematoma. They are different pathologies with different risks.
Let's pivot to systemic factors. We get so focused on the brain, we sometimes forget the rest of the body. What else stops the clock?
Uncontrolled hypertension. This is the low-hanging fruit of stroke management, but it kills people. If the systolic is sitting at 180, 190, you cannot start anticoagulation.
Because you're just maximizing the perfusion pressure against those leaky vessels we were just talking about.
Exactly. You are literally pushing blood through the damaged walls. You have to get the pressure under control, sustainable under control, before you add the blood thinner.
What about the setting? This whole protocol kind of assumes you have certain resources available.
It absolutely assumes you are in a comprehensive stroke center, or at least a hospital with 247 imaging capability.
Right. If I'm in a rural clinic or a rehab facility where the MRI truck comes on Tuesdays,
then you cannot be aggressive. The early start protocol relies on the ability to rescue. It relies on the ability to get a stat CT scan the moment the patient complains of a headache or has a neuro change.
If you don't have that safety net,
You have to be conservative.
that's a really important practical point. The standard of care really does depend on the standard of resources.
Yeah.
Don't be a cowboy if you can't verify safety.
And please don't apply this to non-AF strokes. We said it before, but it bears repeating. This timeline is for atrial fibrillation. If this is a carotid web, a dissection, small vessel disease, throw this timeline out the window.
So it's not one size fits all. It's one size fits this specific physiology.
Correct.
I want to try to synthesize this into a mental algorithm for everyone listening. We've thrown a lot of criteria out there. If I'm standing at the bedside, what's my checklist?
Okay, let's break it down into a simplified traffic light system for that mental model.
Great. Start with green.
Green light. This is early initiation, meaning roughly 48 hours to 4 days. The patient, NIHSS less than 8, the imaging, a small infarct less than 2 centimeters, and no hemorrhagic transformation.
And vitals.
BP is well controlled. If you have all that, the action is start the DOAC.
Clear. Next, the yellow light.
Yellow light. This is the intermediate group. We're thinking initiation around day 6 or 7. This is your moderate stroke, NIHSS 8 to 16.
And the imaging here.
Maybe medium-sized infarcts, or perhaps that very mild petechial hemorrhage we talked about, the HI1. The action here is repeat imaging to ensure stability, then start if everything looks good.
Got it. And the red light.
Red light.
Yeah.
Delayed initiation. We're talking day 12 to 14 or even later. This is a severe stroke, NIHSS over 16. The imaging shows a large territorial infarct or any frank hematoma like a PH1 or PH2.
And lots of swelling.
Significant mass effect or edema, yes. The action is wait, stabilize. Repeat imaging at 2 weeks. And you only start if the bleed has resolved or stabilized and the tissue allows it.
It really makes that old 1-3-6-12 rule look a bit archaic, doesn't it?
Yeah.
It's just so much more nuanced.
It is. The old rule was a heuristic. This approach is personalized medicine. It demands that you actually understand the images you're looking at.
There's one more layer I want to touch on before we close. The patient element. How do you explain this wait versus go tension to a family? Because to them, blood thinner just sounds like bleeding risk.
It's a tough conversation. I usually frame it around the healing brain. I tell them, look, we have 2 jobs here. Job 1 is to stop the next clot from happening. Job 2 is to let the current injury heal.
I like that. 2 distinct jobs.
Yeah, and I explain that the brain bruise is fragile right now. If we start too soon, we bruise the bruise. But if we wait too long, the heart might throw another clot. We are trying to thread a needle that is unique to their family member's brain.
It brings the conversation back to their specific anatomy, not just some abstract hospital protocol.
Exactly. And that builds trust. When you say, I'm waiting 4 more days because the scan shows swelling, that's so much better than just saying, well, the protocol says to wait.
Okay, we're almost out of time, but I want to hit on the confidence level of this data.
Yeah.
Are we standing on solid ground here, or is this just one study's opinion?
We are on very solid ground. Between the ELIN trial, the timing registry, and others, we have thousands and thousands of patients' worth of data now pointing in this direction.
Okay.
The consistent signal is that early initiation in the right patients is safe. We aren't being cowboys here. We are following the evidence.
That's reassuring. So, final takeaway for the clinician listening to this on their commute home.
My final takeaway is stratify, don't guess. Don't just look at the diagnosis of stroke. Look at the severity, look at the infarct volume, look at the blood pressure. If you stratify correctly, you can safely protect your mild patients much earlier than you were probably taught.
And just as important,
And you can smartly protect your severe patients by having the discipline to wait.
it's about having the courage to act early when the conditions are right, and the discipline to wait when they aren't.
Well put.
The guidelines give us the map, but we still have to drive the car. Treat the patient, look at the films, and respect the physiology.
Couldn't agree more.